It's my pleasure to introduce Dr. Afshan. She is an NABL assessor for clinical biochemistry, and she has worked as assistant professor in KIMS. She is also a consultant biochemist in Fernandez Hospital, and presently she is working as consultant biochemist and HOD at Global Hospital in Hyderabad. Dr. Afshan, please.
Thank you, ma'am. So good evening all. I think it is almost the last sessions going on and all are feeling drowsy. Hope my slides won't make you sleep more. So first of all, I thank Mindray Kaho for giving me this platform. And also a special thanks to Shama and Mr. Farid, who have been constantly in touch with me and coordinating about this. So thank you once. Serum ferritin. I'm going to talk about serum ferritin, which is more of inflammatory marker or anemia marker. So since I think I can say before 2020, we have seen that ferritin, as per my experience, since I was told to talk about something related to CLIA, so I picked up serum ferritin. So I'll be talking a brief introduction about ferritin. As we all know about it, still a brief introduction. And the functions related mainly to anemia and inflammation, diagnostic uses, deficiency, and excess. So ferritin, as we all know, is a globular protein complex consisting of 24 protein subunits, forming a halo nanocage with multiple. So as this picture of my first slide shows, this is the ferritin. Ferritin is a universal intracellular protein that stores the iron. So as we all know that ferritin is used mainly a anemia marker for iron deficiency. And it also releases it in a controlled fashion in both prokaryotes and eukaryotes, thus keeping iron in a soluble and non-toxic form. That is, it is converting the ferrous to the ferric form. In human, it acts as a buffer against iron deficiency and iron overload. So one of the properties is that it maintains the iron hemostasis. Serum ferritin is also an indirect marker of total amount of the iron stored, and hence it is a diagnostic test for iron deficiency anemia. Aggregated ferritin transforms into toxic forms of iron called the hemosiderin. So there are many functions of ferritin. So I'll be talking mainly about the iron storage, the peroxidase activity, the immune response, and the stress response. Apart from that, ferritin also maintains the hemostasis, iron hemostasis. Also, it it controls the hyperferritinemic syndrome, and it is helpful in inflammatory diseases. It gives a protection against the free radical by converting the toxic iron into a soluble iron. Obesity also it controls. It also controls the infectious diseases, autoimmune diseases, and mainly it has become one of the COVID markers. After this COVID-19 has come up, it has become a marker for inflammation. And also, it was also an acute phase reactant. It also protects us from malignancy. Coming to the iron storage, the ferritin is present in every cell type, and it serves to store the iron in non-toxic form, to deposit it in a safe form, and to transport it to the areas where it is required. And the free iron is toxic to the cell, so that's why it converts it into a soluble form. And also, if there is a higher amount of the iron is there, the ferritin is related to the hemosiderin. Next comes the peroxidase activity, where the ferritin controls the penton reaction. That is the conversion of the ferrous into the ferric form. And thereby it prevents the release of the hydroxyl radicals. Next comes the immune response, where the ferritin concentration increases drastically in the presence of an infection or cancer. So the same thing I'll be dealing about few case studies where the ferritin levels were increased in the inflammation. And this is mainly because of the endotoxins which are present, which regulate this concentration of the ferritin in the case of the infection and cancer. This was the scenario where in COVID-19 I had taken from one journal, and this is where the SARS-CoV-2, when it attacks the body, it causes the cytokine storm, and this cytokine storm causes the release of the ferritin, causing hyperferritinemia. This hyperferritinemia in turn causes this excess ferritin to bind to this nuclear receptor coactivator 4, and this causes the autophagosomes to release the iron from the ferritin. So these autophagosomes, they release the iron by the degradation of the ferritin, and thereby the intracellular iron increases. This in turn causes the increase in the reactive oxygen species, nitrogen and sulfur species, and ferroptosis, in turn causing the tissue damage. So this was the scenario which was we have seen in the case of the COVID-19, and how this hyperferritinemia was seen in individuals who were suffering from COVID infection. And in the case of the stress also, the ferritin levels have been seen to increase, such as anoxia, which implies it to be an acute phase protein. So now coming to the diagnostic uses, as we all know, it is a immunoassay parameter which can be used by ELISA or CLIA or ECLIA methods. It can be tested, and we use the nanograms per nanograms per milliliter and micrograms per liter, where the conversion unit is only 1. And the serum ferritin levels, we have seen that they have mainly they used to do for the iron deficiency anemia. So since the ferritin levels measured usually have a direct correlation with the total amount of iron stored in the body, so therefore whenever there is iron deficiency anemia, there was a decrease in the ferritin levels also. But sometimes the ferritin levels may be artificially high, mainly because of the anemia due to the chronic disease. So in this condition, we have to rule out the inflammation, and then only we can judge that it is the ferritin is high because of the inflammation and not because of the anemia. So coming to the studies which have been done for showing the iron ferritin as an inflammatory marker. So there was a study done in 2021, and this was after the COVID. They have shown that the cytokine storm syndrome in patients with COVID-19 is mediated by pro-inflammatory cytokines, resulting in acute lung injury and multi-organ failure. Elevation in serum ferritin and D-dimer is observed in COVID-19 patients. This is another study which was done in 2020, and this shows that an inflammatory player keeping iron at the core of pathogen-host interactions. And they have shown that during the infection, both host and the microbe need the access to the iron and avoid its toxicity. So alteration in serum and cellular iron have been reported as important markers of pathology. In this regard, ferritin, first discovered as an iron storage protein, has emerged as a biomarker, not only in iron-related disorders, but also in inflammatory diseases, or diseases in which inflammation has a central role, such as cancer, neurodegeneration, or infection. And even there was one study done in 2021, and they have proved that ferritin measured at admission may serve as an independent factor for predicting in hospital mortality in patients with COVID-19 ICU. So it was even shown that it is not only a diagnostic but also a prognostic marker also. Coming to the deficiency, these were the studies which were done in one was done in 2015, which showed that ferritin level below 30 nanograms per ml indicates iron deficiency, while a level below 10 nanograms indicates the iron deficiency anemia. And WHO has stated that iron deficiency in children below 5 years is below 12 nanograms, whereas it is below 15 nanograms per ml in children above 5 and over. And also this low serum iron is more specific in lab finding for iron deficiency anemia. And however, it is less sensitive if it is increased in the blood by infection or any other type of chronic inflammation. So this is one study which we have seen in the second wave of COVID in my hospital, where one case had come, a 66-year-old male came to hospital with history of fever, SOB since 1 day, and dry cough with history of travel. And the vitals were normal on examination, and SpO2 was 94% at room temperature, and HRCT showed cohorts 5 with 80% lung involvement. So in this patient, we noted that it was COVID was tested and it was positive. D-dimer was like it was low, and when the patient was admitted, it was low. And by the time of around 5 days, it became high. NT-proBNP was normal. LDH also was low at the time of admission, and later on it increased. But the ferritin was 111, and later on it reduced to 53. In this patient, actually iron study was not done. It was a comorbid case. It was brought in ICU. So that's why I could collect the data from the CBP, and I noted that the hemoglobin was 10.9 at the time of admission, and later on it decreased to 9.5. And peripheral spheres showed hypochromic microcytes. So the reason for ferritin to low in this case could be the iron deficiency anemia, which was it was not much looked upon it, since the patient was COVID-19, and so on that based the treatment was given for infection only. Now, excess of the iron. If the ferritin is high, there is iron in excess, and or else there is acute inflammatory reaction in which ferritin is mobilized without iron excess. For example, ferritin may be high in infection without signaling body iron overload. So ferritin is also used as a marker for overload disorders like hemochromatosis and hemosiderosis, apart from the inflammation.
Dr. Afshan, please finish it in 2 minutes.
Ferritin is also an acute phase protein, and it's often elevated in the course of disease. And in the case of to rule out anemia and infection, we can also do the CRP levels to check whether the ferritin high is because of inflammation or because of anemia. So these are the 4 case studies which I have seen. One is a 65-year-old female. She came with a history of fever, cough since 6 days, and SOB of grade 2. Vitals were normal. SpO2 was 94. And cohort 5 was there in HRCT and more than 30% lung involvement. So in this patient, D-dimer was done, NT-proBNP and LDH, they were all normal, and the ferritin was only 682, and the patient was COVID positive. So in this patient, I could say that ferritin was mainly the inflammatory marker with which we can rule out there is a viral infection. But all the other parameters were normal. Another case study which was in a 71-year-old male. In this patient also, there was cohort 5 with more than 40% lung injury, and D-dimer, NT-proBNP, LDH were all normal. Only the ferritin was more than 1200 nanograms per ml, and patient was COVID positive. In this scenario also, it was the same. On the day of admission, ferritin was high, and then by the 5th day, it reduced to 572. And we did IL-6 also, it was normal on the day of admission. D-dimer, NT-proBNP, LDH were all normal. So we can say that the ferritin is more of the inflammatory marker now presently, because people have become more conscious with their health, and iron deficiency has become less now. So now whatever cases are coming to our hospital, mostly with the viral pneumonia, we are using mostly ferritin as a inflammatory marker. This is another scenario where again LDH was little high, but ferritin was 1121.9 nanograms per ml, with more than 30% of the lung involvement. So with this, I can conclude that the low levels of ferritin can be used as an anemia marker, and high levels can be used as an inflammatory marker. Thank you. These are my references.
Very nice presentation, Dr. Afshan. Any
Thank you,
questions?
No questions. So may I request request Dr. Vinita to hand over the certificate to Dr. Afshan.